as Andy said, my job here is to synthesize what I've heard, what I read in the RWJ Alternative Futures paper, what I heard today, and try to integrate it into our understanding of the triple aim. First thing that I'd like to tell you is that I found all the presentations just exceptional. When I think about the organizational leadership, resiliency, capability building that has occurred in the organizations that I heard from, and I have no doubt it was the same way in the other room, it is such a great advance over the years as far as building that capability for improvement. My prediction is, though, that as we go into the future, the metrics that we use to determine capability will be more outward-facing. Most of the metrics that I heard about were about engagement within the organization, which is critical. But how we apply that outward-facing in the community and start thinking about community capability, I think will be a critical piece as we move forward. Some overall impressions that I got from the RWJ piece. It's a time of great uncertainty and chaos. It will require learning and adaptation. And as some of the lean advocates would say, it means do, see, know again, again, and again. So that leads me then to the triple aim. And the question is what have we learned at IHI since Tom Nolan, John Whittington, and Don Berwick coined the term in 2008? It's a simple proposition, frankly, and it is, we'll advance the health of the population, we'll improve the experience of care, and we'll aggressively manage per capita costs simultaneously. So let's look and unpack those three aims. Per capita costs. What are they, and why are they? I think about McAllen, Texas, and I think about the cost conundrum that Atul Gawande wrote about in terms of the Medicare per capita costs in McAllen. And I thought, my goodness, how could they have a community like that? And then we hear that, well, their non-Medicare costs offset their Medicare costs. And we have a debate as to what the actual performance of the community is. We're getting to a point where we do have big data. We do have all-payer databases. And the question is what are the reasons for variation? What is the causation for those per capita costs? And how do we leverage big data for improvement? Not for judgment, not for blame, but for improvement. The second thing we think about in terms of improving the experience of care is are we doing that purely within the clinical model? And we would say no. We would say that there's too little leverage in improving purely the clinical model, that it's that integration between the social and clinical model for functional outcomes that's really important. And so we say that any organization should move from the question to the patient or to the person of what's the matter, to a question of what matters to you. We also think that it's very, very important that the patient is brought into design. We used to think that designing cycles of care with the patient in mind was sufficient. We don't. It's not just with the patient in mind, it's with the patient involved. Thirdly, in terms of advancing the health of the population, the question is, what population? Are we talking about a plan's population? Are we talking about an employer's population? Is it disease-based, condition-specific? What about social determinants? What about hotspotting? So you can see that while there has been great take-up of the term triple aim, we're finding that the results, at best, are spotty. And perhaps there's a lesson here as we collectively move forward in our aspirations for scenarios 3 and 4, big data, big health, and a culture of health. So I think these aims are disruptive. And I think they're disruptive because they don't really contribute to the profit and loss statement and balance sheet of all the organizations that you represent. And if they don't, how then will you work with these aims and aspirations? I also think that there is some countercultural aspects here, especially in self-care, that confront what you have as a deeply embedded expert culture. And why not? You have people, including yourselves, that have worked long and hard to build that expertise. But I think the consequence of this cultural assessment and the business model assessment is that as we move forward in aims 3 and 4, we're going to put one foot on the gas and one foot on the brake. Or worse, we're going to force these concepts, these aims, into an organizational construct that corrupts them. One of the things that we're finding is that while it was, and still is in some environments, very challenging to improve at, say, the intensive care unit level, it pales in significance in terms of the complexity to improve at a total health level. Edwards Deming said, the father of quality improvement and improvement science, said that the most important element in improvement is cooperation. And so the task of developing a cooperative approach is critical and vastly more complex as you move down this slide. So when we talk about the triple aim, we're really focusing on broad cycles, broad population segments. Now I want to cover the impact of disruptive innovation. This comes from Clayton Christensen and Jason Wang, who wrote The Innovator's Prescription. So I'm going to ask a question. How many of you know what this is? How many of you have used a slide rule? Oh boy, I just see a few. How many have never heard the term slide rule until now? I'm sure there's a few. Well, what happened to the slide rule? Well, the slide rule got replaced by a mainframe computer. Now, the issue with the mainframe computer is, as you can see, there were millions of slide rules. But when we got to a mainframe computer, when those were first invented, there were about 5 people in the US that knew how to run them. It was an expert-based technology. What happened to that expert technology? Well, it got progressively decentralized. In other words, the capability of using the technology was invented such that we all have smartphones now. We all have iPads now. So what happened to the leading computer manufacturer who in 1984 was identified as having the best management team in the world? Digital Equipment Corporation. Has anyone here heard about their level of success in 2012? How about 1999? How about 1992? Yes, they went out of business. Why did they go out of business? Well, they went out of business because in 1984, their CEO said, quote, "There's no place in the home for a computer." There was a time in the case study where DEC said, holy mackerel, we were wrong. We've got to figure out how we can get down here. And they were unable to do it. And the reason they were unable to do it is that they had deeply embedded beliefs about the kinds of expertise they were willing to work with out in the marketplace. And it wasn't you and I. It was the director of a highly technical information technology department in a large organization. They were never able to make the leap to a retail orientation. So in the space of 6 years, the best in the world, most competent, did they really change? Did their IQs go down that far in the space of 6 years? No, they were disrupted. Now, lest they get comfortable, what about this? What about the edifice? What about the medical center? Whether it's an academic medical center or it's the medical center. We have, over the years, centralized our expertise because we believe that that's the most effective approach. Cost-effective approach, best use of our experts. They're very expensive. But as we move forward, we're starting to see that this gets decentralized. And we're starting to see that people that had great expertise are giving away to people that have less expertise, excuse me. And so when I say, will the experts allow scenario 3 and 4 to evolve and become successful, we have to ask ourselves the question, what's happening now and what are we doing about it? This has a high impact, I should say, on the viability of that central organization. And the question is, are you that DEC CEO? Or are you that innovator who's willing to serve the present but shape the future at the same time? Here's another way of looking at it. Now, I have to spend a little time to describe this chart. We'll call these model life cycles. That's a euphemism. And as you go higher on the vertical axis, that suggests that you're more viable. More viable as an individual, more viable as an organization. And down here on the horizontal axis, we have a combination of things. We have a clinical model, in this case, episodic care. We have a business model called fee-for-service. And we have an infrastructure that can afford to be segmented because we're working on a fee-for-service basis. And boy, a lot of us have done really well on this model. Really, really well. Trouble is that some of us are starting to think maybe it's starting to tail off. And the question is, if you look at this dot, is that the point of inflection? In other words, if you wait that long, are you going to be in a place where you're going to go out of business just like digital equipment did? Well, the question is when do you hop the curve? And what are you hopping to? Well, thinking is that maybe you're hopping the curve to a clinical model of coordinated care with a business model of some kind of bundled payment or capitation, and it requires an integrated infrastructure. And this requires a major investment. So what is this line or this oval here? Well, what that oval relates to is transforming the organization. So you have the task as a leader, and I heard a lot of this in the presentations, and I was really impressed with the fact that you're optimizing the current model. You're optimizing your productivity. You're getting better, safer environment. The question is that going to get you to where you want to go? Is that going to get you to a place where you're serving individuals in the community well? Or do you want to move to this next curve? Some people think this is the ACO curve. Others think of it as the medical home curve. It could be many things. So what does it mean to transform the organization? Well, it means you've got to do the do, see, know. It's adaptive leadership. You've got to learn your way through it. So it's about new beliefs, behaviors, relationships, new customers. And the question is where are you on this curve? Now, what I saw in scenarios 3 and 4 was more this third curve, more about patient-directed, population-based models. Is there a business model? Well, not really. I just put disruptive innovation. I'm not quite sure what this business model is. There's a lot of question as to why isn't there a greater take-up of home medical devices. And it may be because there's just not a business model for it. What is the infrastructure? Well, it's already here. The cloud infrastructure would allow for a fully integrated health record, all in, if people permit it and are willing to pay for it. How do you move over here? Now, you could look at this diagram, and Alex Anderson, my research associate, and I were looking at this, and I thought, this is really great. This is a fantastic diagram. It's symmetrical. It says everything it needs to say. The problem is that it's wrong. This is what's right. The question is, well, are we here? Is this just a bump? At IHI, our revenue is not growing. Is it just a bump? Fred Hessler told me earlier today that every not-for-profit that he's approaching is having the same difficulty. The revenues just are not growing. So are we in an inflection point where we need to hop to a brand new curve? In other words, we're too expensive. Face-to-face learning and improvement simply doesn't bring the value that you all are looking for. We've got to go to something else. When do we make that move? So you're thinking about the same thing, and the problem is, I've heard people say, you know, I've heard about bundled payment and capitation since 1980, hasn't happened yet, never going to happen, I'm over here, this is what I know. So the question is how do you deal with this? Both in terms of optimizing a current model, transforming the organization. How do you make the change? How do you make the decision to make the change? And I would suggest to you that the key in this is the patient. That if you stay close to the patient and meet their needs, if you ask the question, what matters to you? If you bring the patient into the design, that patient and patients will carry you through these curves because they will make the decisions for you and they'll be the right decisions. I was asked by a journalist when I said this, is that an act of faith? And I said, yeah, most hopping of the curves are acts of faith. So why is finding your love and compassion critical in an environment of uncertainty and chaos? And why is it important for scenarios 3 and 4? Well, my belief is that in times of uncertainty and chaos, we perceive scarcity, not abundance. And if we do not find that love and compassion, we will do everything to defend and retain whatever power we have. And that is not going to get us to scenarios 3 and 4. Because as Paul Tillich, the eminent theologian, has said, love without power can never achieve justice, but power without love can never be just. Now, as I looked at the likelihood and preferability of what you did this afternoon versus the Kansas City group, I really think the love and compassion is in this room. Thank you very much.